Welcome to this month's Strive Learning Lab on Strive and the SDGs, which will be presented by Katherine Fritz and Laurie Heisey. So maybe just to introduce Strive a little bit, for those of you who don't know us yet. Strive is a research consortium funded by DFID to tackle the structural drivers of HIV. And the consortium partners are in India, Tanzania, South Africa, the US, and the UK. And have been and continue to conduct research into a range of structural factors, including alcohol, transactional sex, gender norms, stigma, and violence. So we do these learning labs quite regularly, and all of our previous learning lab presentations are available on the Strive website, along with a series of materials addressing issues and structural drivers. So please feel free to visit the website and check out all these very useful materials. I just before I hand over to Katherine and Laurie, just to maybe place this within a broader context of what we're doing at Strive, we're now in an extension phase where we're trying to synthesize the evidence that that we and others have been generating over the past couple of years on structural drivers. And we have developed, as part of that, two what we're calling meta-narratives. And basically, they're trying to pull together the different strands of evidence and kind of distill the key messages that are coming out in different areas and framing that towards different audiences. So one of them was more targeted at an HIV audience and was considers how structural drivers impact on the HIV prevention and treatment cascades. And that was already presented by colleagues. And the second one, which is what you're going to hear today, is really aimed at a broader development audience and frames the evidence more in the context of the UN Agenda 2030 for Sustainable Development and the Sustainable Development Goals. So without further ado, I'll hand over to Katherine and Laurie. I'm not sure who started. Maybe just to very briefly introduce them for those of you who don't know them. Katherine is a director of research at the International Center for Research on Women and is based in Washington, D.C. And she's been part of Strive since its inception, and her areas of expertise are around gender inequality and alcohol use as drivers of HIV risk, particularly in sub-Saharan Africa. And Laurie is a professor at, I'm just reading a thing. She's recently joined the faculty of Johns Hopkins Bloomberg School of Public Health as a professor, where she conducts research on violence, social norms, and health, and serves as a technical director of the Prevention Collaborative, which is a new global initiative designed to support evidence-based GBV prevention programming in the Global South. So I'll hand over to both of you, and everyone, please do remember to type in your questions as we go along, and we'll have time for discussion at the end.
Great. So this is Laurie. I think I'll start. And as Michelle already said, what we really wanted to try to do, it occurred to us as we were coming to sort of the end of our Strive program, that a lot of what we had learned in terms of how to think about issues was going to be really applicable as we went into this new era of the SDGs, the Social Development Goals. So today's talk, we just wanted to say a bit about what we've learned in terms of how intervening on structural drivers could be useful to formulate strategies for achieving the SDGs. So as Michelle already said, Strive has been going for about 7 years now, and we've been focusing on what we like to call the upstream factors of risk. So things like insecure livelihoods, unfettered alcohol availability, stigma and discrimination, and gender norms and gender-based violence as the kind of structural conditions that affect the acquisition of HIV and its onward transmission. And because we've been doing this, this mandate has actually forced us to think about these issues quite differently than we have in the past, and to think across sectors and to try to figure out how we can achieve greater cost efficiencies in development by investing upstream. And as we enter this era of the SDGs, it occurs to us that that's exactly the kind of thinking that government and donors are going to need to do if we're going to tackle these 17 new global goals. So we find ourselves sort of at a moment of convergence, where in 2015, the world communities come together to set the new agenda for the next 20 years until 2030 in terms of what we're going to take on as a global community and as a new way of thinking about and planning for the future. The SDGs signal where we want to be in terms of our economic, social, and environmental targets. And significantly, they're both indivisible and interdependent, and they're really a system of goals, which is quite different than what we were dealing with when we were looking at the Millennium Development Goals, which were very sort of isolated targets. So in 2011, when STRIVE was established, we were really focused on the HIV epidemic. And our goal was to sort of replace short-term thinking and vertical program with a type of systems thinking about how to address HIV risk. And also not just HIV risk, but how to achieve multiple development outcomes downstream, which is what we call achieving development synergies. And it's our firm belief that we're really not, as a global community, going to be able to achieve the SDGs without applying some of the same type of intersectoral and upstream thinking that we've been trying to do in the STRIVE program. So today we'd like to share with you a little bit about the lessons learned and with some thoughts about informing the SDGs. So first, let's consider the case of HIV. And this is basically the case that we at STRIVE started with. Traditionally, HIV programming has been very vertically driven and highly disease specific. Back in 2015, when UNAIDS set its global target, it was to eliminate the epidemic by 2030 using a strategy known as 90-90-90. And what that is basically largely a treatment as prevention strategy, that if we could get 90% of HIV positive people tested and knowing their status, and that 90% of those people would be connected to services and on ART or on treatment, and that 90% of that subset would actually achieve viral suppression, that we could, in effect, stop the epidemic in its tracks. And that was really the strategy that has been the core of the approach to HIV over the last 5 years. But this strategy is now being called into question, both in its wisdom and its feasibility. So a recent article in BMJ Global Health conducted a systematic analysis of the national HIV treatment cascade, sort of asking the question, can the UNAIDS 90-90-90 strategy be achieved? And then a highly influential editorial the next month came back with an answer, no, that UNAIDS target is not realistic. So let's look at why folks are saying that. So right now there's still 36 or almost 37 million people living with HIV today, and in 2015 there were over 2 million new infections recorded. And while the overall number of HIV-related deaths has fallen by 50% between 2005 and 2016, AIDS-related deaths among adolescents and young people increased by 50% to approximately 55,000 deaths. And importantly, in hyper-endemic regions such as KwaZulu-Natal and South Africa, there's been no reduction in the incidence of HIV in young women in the past decade, despite the biggest ART program in the world. So you can see that on the right-hand side of this slide that we are on track to meet the goal of reducing new HIV infections among children, so that's PMTCT, but we're really failing far short when it comes to HIV infections among adults and adolescents. In fact, a recent modeling effort by Medlock and colleagues estimates that with the current rate of ART initiation, we're still going to have 49 million more new HIV infections by 2035. The editorial goes on to argue that not only would a disease-specific agenda focusing on HIV be unlikely to succeed, it may actually prove counterproductive. The authors, they observe, and I quote here, meeting the future resource needs for AIT scale-up under the 90-90 scenario, which is about $18 billion per year globally, will require significant additional resources, which may jeopardize funding for other health programs. And besides resources, there are other reasons to question the viability of a largely or singularly biomedical focus to HIV. First, UNAIDS modeling itself suggests that at best, even if we had 90 to 95% coverage, which itself is unlikely, treatment will be able to avert only 60% of new infections. Plus, the virus is actually becoming more dangerous. Phylogenetic testing suggests that the recent HIV infections are 30 times more infectious than older ones, meaning that they can spread more easily. And finally, largely due to adherence issues, treatment may be consistently less protective than we had hoped. So, for example, U.S. HIV patients who are on treatment are at risk of transmitting the virus almost 25% of the time because they're not fully virally suppressed. So this slide actually compares the UNAIDS targets for 2020 for universal treatment with the global estimates of what's been achieved by 2015. And according to UNAIDS, as I said, there were those 37 million people who were HIV positive, so that's that red bar. So that's the people that really need to be reached. And in the systematic analysis of sort of how far we have come, what we find is, this is looking at 69 different countries. None of the countries had met their targets. And globally, if you look across, 54% of people living with HIV, or only 54%, know their status. So as you can see, we're considerably below our 90% target at this point. They found that diagnosis, so that's at 90%, range from 87% in the Netherlands, so almost there, to 11% in Yemen. And of course, Yemen's in the midst of a war, so not surprising. But that means that on average, only 54% of HIV positive people know their status, and rather than the 90% of the goal. Target 2 is that 90% of those who know their status, or 81% of all HIV positive people, so that's the 81% in green there, should be on treatment. In point of fact, treatment coverage ranged from 71% in Switzerland, which again is fairly close, to an abysmal 3% in Afghanistan. The yellow bar at the end shows that less than half of those that are on ART are actually virally suppressed, or again, less than a third of people who are HIV positive in those 69 countries. For those interested in the U.S. example, only 52% of HIV positive people on treatment are on treatment, with 82% having viral suppression. So that really illustrates the difficulty of maintaining not only early diagnosis, but the kind of sustained medical and social support required to achieve optimal suppression and therefore be able to prevent onward transmission. So recognizing this, STRIVE has focused on, as a consortium, on primary prevention, specifically targeting those upstream factors that we talked about before. And so I'm going to turn it over to Katherine now to lead us through some of our thinking about the application of STRIVE to the SDGs.
Great. Thank you, Lori. Hi, everyone. This is Katherine. So I think Strive, our thesis has always been that one of the main reasons why we will fall short of the ambitious targets is the neglect of some of the structural drivers of HIV. So when we set out our research agenda, we chose some drivers that we thought were particularly influential in shaping vulnerability to HIV infection, as well as inhibiting people's access to and adherence to treatment regimes. So as you can see here, these are the drivers that we chose to focus on. So what we're going to do now is just kind of unpack a few of these, and we've gone through some exercises ourselves, which has been very revealing in terms of mapping some of what we've learned about the structural drivers of HIV vulnerability to the various SDG goals and targets, just to see where the synergies lie, because our goal with Strive has always been to not only understand these individual drivers of vulnerability, but also understand the way they interlock together and what these synergies are. And that implies that solutions, of course, have to be upstream solutions. They have to be multi-sectoral, and they have to involve investments from a multitude of stakeholders. So just a little bit more about the Sustainable Development Goals. I think as everyone is becoming much more familiar with these as we go along, there are 17 interrelated goals that the global community has committed to back in 2015 to address economic, social, and environmental issues that threaten both human flourishing and the Earth's vital ecosystems. So each goal in itself is an enormous agenda, and there are tons of sub-goals and indicators under each. For example, the goal on health, it has 13 sub-targets and 26 individual indicators. So just when thinking about the fundamentals of the SDGs that we all have to be aware of as we start to use them and understand them and work towards them, 3 pillars are extremely important for us all to kind of be on the same page about. They are universality, integration, and leaving no one behind. So this is where the SDGs differ greatly from the Millennium Development Goals, also because they apply to all countries and not just low and middle income countries. So the SDGs are in fact not a list of separate goals, but rather a system, as Lori mentioned, a network of highly connected goals across these 3 dimensions of economics, environment, and social impacts. And reaching the furthest behind first is particularly important under this new development agenda, which aims to tackle inequality and ensure that all people benefit from SDG implementation. So this means that we can no longer monitor our progress simply in terms of population averages. And in fact, we must ensure that individuals who confront multiple interlocking disadvantages also benefit. So not surprisingly, achieving the SDGs is ambitious and could be a hugely expensive undertaking. And understanding that all countries face resource constraints, it becomes extremely important to start to prioritize. And so that's what we're going to talk about now, is that what does that prioritization look like, and how can we be smart about these investments in the SDGs? So we were highly influenced by this article in Nature, which was suggested to us by our colleagues at UNDP. And it provides a way to start to identify what the authors call sweet spots. These are opportunities to invest in one area that yield multiple benefits without undermining other goals. So it emphasizes the reality that the SDGs are a system, an ecology, and we must examine how different goals and targets support or potentially undermine each other. So you can see on the right that the Nature authors offer a first attempt at kind of the scoring scheme for identifying best investments across sectors. And it encourages planners to consider investments in light of how they would interact with other goals and targets. And among the things to notice is how they define what it means for goals to be reinforcing, enabling, and indivisible. And these are the three categories that we looked at as we looked at the structural drivers of HIV and our research on those drivers to better understand how they interacted with other SDG goals and targets. Strive has identified, as I said, a set of key social and structural drivers that offer these investment opportunities. So we're going to examine a few of them specifically. There are lots of different directions we could go in, but we decided for this presentation to focus on three so we could dive a little bit deeply on those. So what those are: addressing harmful alcohol use, keeping girls in school, and expanding social protection. So we did some mapping exercises to better understand how these three different goals and targets could be mapped using some of the evidence that we've gathered through Strive. So we're going to start with the prevention and treatment of harmful alcohol use. And this appears in the SDGs as part of Goal 3. It's actually Target 5. And of course, we were very excited to see this issue come up and be called out in the SDGs. And when we look at the prevention and treatment of harmful alcohol use, which is, clearly a driver of HIV risk in many high prevalence countries, we saw connections to all of these SDGs that you see here, from hunger right through to decent work and economic growth. So we're just going to map out a few of those connections for you. Obviously, the biggest connection is around good health and well-being. That's the place where you find the most indivisible connections between preventing and treating harmful alcohol use and some of the other targets under good health. So for example, 5.1% of the global burden of disease and injury is attributable to alcohol as measured in DALYs. And most of this burden is due to chronic NCDs. So this is liver cirrhosis as well as a whole range of cancers, in addition to road traffic accidents, which are a leading cause of death, especially among men in many HIV high prevalence countries. So this is a place where we see a lot of places where we see opportunity, a sweet spot for this indivisible quality relationships between alcohol use and other health issues that are going to be of great importance to the countries where we are working on HIV as well. I want to look at gender equality as well, because this is something that we have been examining in our work on Strive. And we know that harmful alcohol use has been associated with a 4.6-fold increased risk of exposure to intimate partner violence compared to mild or no alcohol use. And this is just one example of the different various ways that gender equality and alcohol use are interconnected, both through violence as well as the ways that transactional sex can take place at drinking places, and alcohol is used as a commodity to help that actually exacerbates the connection between risk behavior and HIV infection. We also know that alcohol attributable loss is very important for workforce productivity as well as safety at the workplace. And these are targets that show up in Goal 8, decent work and economic growth. And we also know there's a strong relationship between maternal alcohol consumption, which is significantly associated with under 5 malnutrition. So this is one way that we can call out the connections between health and the good health and the hunger goals. In addition, one thing to think about as well is the extent to which in many low and middle income countries, the agricultural system is producing great amounts of grain that are actually then funneled straight into alcohol production rather than food production, and the way that land and agricultural land is used to feed that industry as opposed to providing more nutritious food for their populations. Quality education is something that we've been looking at a lot as well, in terms of looking at the connections between alcohol use and HIV risk behavior, especially for adolescents in the 3 countries in which we work. And for example, we know that substance use is strongly associated with attending a lower level of secondary education than expected. And in addition, I just wanted to show you a slide that comes from our research in South Africa, where we used GIS mapping to look at the concentration of alcohol sales outlets and bars in relationship to the location of schools. So one of the SDG targets is around creating positive enabling school environments. And what you see here on this slide is that the stars with the little white in the middle are actually schools, and all of the red stars are taverns, bars, pubs, and bottle stores. So you can see there's virtually no school in this 2 square kilometer area that doesn't have multiple bars and bottle stores around it. And the other things that are mapped on here are advertisements, which change on a regular basis and are constantly promoting alcohol consumption and in ways that also help to promote gender stereotypes. So and there is a law in South Africa that all liquor selling outlets have to be more than 500 meters away from schools, and that's flagrantly being violated. There's not one school for which that is the case. So the final thing I wanted to call attention to, just as an illustration of some of the connections that don't seem quite obvious, but the SDGs help us to identify. I included clean water and sanitation here because the goal around sustainable water use and protection is incredibly important for the environment. But what we know is that water demand in 2030 is expected to exceed current supply by 40%. And it's interesting to note that it takes 300 liters of fresh water to produce 1 liter of beer. And we know that beverage industries in low and middle income countries use enormous water resources, sometimes with great subsidizing from governments on that cost. So that is yet another target where you could find some sweet spots in terms of finding policymakers who are interested in the connections between the beverage and the alcohol industry and the need to protect water resources. This is just one other graphic that we created in our effort to try to identify these different sweet spots and create a heat map where you can see that the dark green represents targets that are indivisible. The middle green color is reinforcing, and the light green is enabling. So you see here basically the same information that was on the previous slide, but in a slightly different way. You can see that the indivisible targets definitely fall in under good health. We have road injury and traffic death prevention, promoting mental health, reducing NCDs by 1/3, as well as ending the AIDS epidemic by 2030 as a reinforcing goal. So these are all places where investments in reducing harmful alcohol use can have multiple downstream impacts. But you see other places, many other reinforcing relationships under decent work and economic growth. We mentioned economic productivity, also policies to promote decent job creation and decent work, reduce youth unemployment, for example, as well, and gender equality. So this is just, we offer this up also as an exercise that could be useful for folks to do on various topics that are of interest to you to create this type of heat map that you can then potentially use as a planning tool as you move forward and decide who you want to talk to about co-investments. So the other example we wanted to give you, the second example, is ensuring that all girls complete free, equitable, equality primary and secondary education. We'll spend a little less time on this just because I know time is running short. We want to make sure we have time for questions and answers. But this slide goes through the same process, basically showing the relationships between women's education and reduced hunger and dietary diversity. Modeling suggests that improved education for women could account for up to half of the global improvements in child mortality under health. We know that each additional year of education for adolescent women results in 9 fewer births per 1,000 women, so connected again to to Goal 3. For the poverty goal, we know that an extra year of secondary schooling for girls increases their future wages by 10 to 20%. And finally, we know that in Botswana, each additional year of secondary education among adolescent girls reduces HIV by 8.5% in that population. So again, more examples of the ways that these goals and targets interlock, and some inspiration for what we're going to talk about a little bit later in the presentation around co-investment and the different best buys for both HIV prevention and other targets among the SDGs. So I'll turn it back to Lori now to talk about social protection and cash transfers.
Great. So again, I don't want to take up a lot of time because with this, but it is sort of a third example. One of the things here that I think is very interesting is that actually if you look in terms of the impact of cash transfers or the social protection programs directly on HIV, you see some interesting results. So for example, there is a randomized controlled trial in Malawi and also one in Kenya, together with some quasi-experimental designs in South Africa that demonstrate that cash transfers can reduce HIV risk behavior among adolescents and especially young girls. And then if you go through the exercise that and actually read this, you'll see that, you know, again, there's these incredibly strong linkages with some of the other SGD goals. So let me just go through here. For example, households that receive transfers spend more on food, resulting in significant gains in children's weight and height. All of these different connections, which you can read at your leisure, are taken from a big global overview, a systematic review conducted by the Overseas Development Institute on the impact of cash transfers. And cash transfers are actually one of the interventions that has received the most serious evaluations and impact evaluations. And so we actually have a fairly good evidence base to be able to sustain some of these observations. So looking on the right-hand side there with gender equality, that when they have looked at the impact of giving cash to households and especially to women, we've seen both effects on women's decision-making power and choices, including related to whether and when to get married and how many children to have, as well as reduced physical abuse by partners. And we at the part of Strive and at the London School just completed a large systematic review of the impact of cash transfers on partner violence and are seeing some significant reductions in physical abuse across multiple studies. Here, I just wanted to note the impact of a program in South Africa, again, on risk behavior. And what this slide is showing you is it's comparing girls to boys in terms of the percentage that have, in a follow-up study, have engaged in risk behaviors over the past year, and comparing those that receive no support on the left, so those larger, higher bars, those who receive only cash, and those who receive what the authors are terming cash plus care, which is the care is a program of dealing with parents, helping them be better parents and engage more with their adolescents. So what this graph, I think, shows is that while cash actually has a direct impact and fairly substantial one in this setting, that, you know, these additional programs that can be added on the backs of these cash transfer programs can buy you some additional impacts on HIV risk-related behavior. This is also from that study, and this is looking specifically at cash in the form of what they call in South Africa the child grants. So you get them if you have children, and this is looking at the impact of the child grant program in South Africa on the prevalence of either transactional sex or all types of transactional sex, as well as those where you have a big age disparity between the women and the older men. And what you see here, again, is the left-hand gray bars are young people who are growing up in households without the cash transfer, and the blue bars are the HIV incidence in, not the HIV incidence, the transactional sex and age disparate sex incidence amongst young people who are growing up in households with cash transfers. So I think what we're trying to point out with all of this is sort of the opportunities to act on these multiple investment where you can find those, as the Nature article called them, the sweet spots, where you can invest upstream and figure out or see demonstrable benefits or synergies downstream. The problem with that is that the system itself is not particularly well set up to encourage that type of behavior, because basically most of our decisions at a country level are made by vertical ministry. So it's health versus the finance ministry versus the gender ministry. And so it makes planning for these kinds of investments quite difficult. And one of the key things that we've been working on here at Strive, and especially Dr. Remy, who introduced us in the beginning, was that some of the problems that are inherent in the fact that of the way that we actually establish the cost effectiveness or try to evaluate one intervention opportunity or investment opportunity against another. And that normally when people are actually trying to figure out if an intervention, let's say a cash transfer or condoms or PrEP, for example, are cost effective, what they do is they figure out what it costs to deliver that particular intervention, but it's only against a single outcome. So if it's an HIV intervention, let's say cash for HIV, all of the costs of the intervention are balanced against the benefits with HIV, even if that cash or that cash transfer and social protection program yields multiple benefits like the ones that we've been laying out over the course of the presentation. So I'll give you an example here. This is this cash transfer project in Zimbabwe, where they were comparing giving cash, small amounts of cash to households and also directly to young girls, some of whom were out of school and some of whom were in school. And the cash was, some of the cash was in one arm of the trial was conditioned upon young girls returning to school or staying in school, and some was just actually not conditioned at all, so you got the cash regardless. And what they found is that even amongst the girls who got the cash regardless, if they were in school at baseline, you saw a big outcomes on a whole range of different development concerns. So there was a 35% reduction in school dropout, a 40% reduction in early marriage, a 30% reduction in teen pregnancy. So all of this from that initial cash transfer. Now, what we were focusing on, or what the authors were focusing on, were specifically the impact on HIV, which is there at the bottom. So there was a 64% reduction in HIV risk. But when they go to actually, or when health economists go to actually figure out the cost effectiveness, what they do is they look at all of the costs of the program on the left-hand side against the benefits to HIV, ignoring the benefits in the other outcomes. So, of course, it makes it much more difficult for something to look cost-effective. So what we've been doing in the STRIVE program is working to develop a methodology in order to actually figure out how to do cost-effectiveness assessments against multiple development outcomes so that you can actually capture the multiple benefits. And the problem with that is that's an important first step in allowing this kind of thinking. But you also then have to operationalize it, because what it requires is co-financing. And what we mean by that is if something, for example, a cash transfer gives a certain benefit to the HIV sector and another separate set of benefits to the educational sector by keeping girls in school, and another group of benefits to the sexual and reproductive health sector by reducing teen pregnancies, there's really, the goal would be that each of them would contribute into a basket of funding to make that program be sustained and work. But that actually requires an entirely different planning and financing model than what exists in a lot of the current programs. So our next phase of the final 2 years of STRIVE is really going to be focusing on trying to work with our partner at UNDP to operationalize these approaches in development practice. And what we mean by that is actually try to work with in-country partners at sort of a district level to say, all right, let's actually look for those sweet spots, those investments that make sense, and see if through a local planning process we can actually negotiate these kinds of joint co-financed investments in order to allow them to be sustained. So finally, I think when we kind of look across the arc of what we've been trying to do in STRIVE and sort of the challenges that are on the horizon with the SDGs, I think what we've realized is that, yes, there are both opportunities and challenges, but some of those challenges are technical, like this, how do you figure out which of them are the best investments, and how do you do these new forms of health assessment or cost effectiveness assessment. But fundamentally, it comes down to political questions of how do we get governments and ministries to co-invest, and how do we get a development industry which is been sort of addicted to vertical, more focused programming to think more structurally and in the system way, which is really embedded in the SDGs. So I think our final thought on that is that, going back to what HIV has taught us, is that in addition to the investment for all of the technical solutions, we really need to ensure that civil society and NGOs and activists are engaged in this to try to keep the accountability pressure going, because the most important things that we gained in the HIV world were not those that were the technical solutions, but the kind of challenges that the activists put to us as professionals to say that it can be done, or those things that we thought couldn't be done can be done. So I think we'll stop there.
Like Diane Kingston has a question. She says, I'm interested in Goal 1 in social protection and cash transfers. And in addition to cash transfers and improved decision-making on SR/HR, you have made links to SDG 16 on decision-making processes and mechanisms at a local level. And she's curious about that.
I think it was actually a reference to household decision-making as opposed to local decision-making. So there is evidence that cash transfers are able to, in some circumstances, improve women's ability to control money within the household or to have greater influence over household decision making. I don't recall an issue around kind of local decision making, if you mean like at a governmental level.
Okay, fantastic. So yeah, I'm Diane Kingston. I'm a senior advisor at the International HIV/AIDS Alliance in the UK, so not far from you in London. And I'm currently doing a piece of work looking at the intersectionality of the SDGs and HIV across the board. One of the key targets around Goal 16 is increased involvement in decision making in all processes that affect people's lives, whether that's at a local level or a national level, and in terms of holding governments, whether that's local or national, to account on what they're doing. So I was quite interested in mechanisms to ensure that the voices of people living with HIV and key populations are increased, and whether you have any evidence around cash transfers, not just helping in people making decisions about their lives at a personal level, but whether that actually helps them engage with decision maker fora at a local government level or at a district level, for example.
I personally don't. I don't know if there's anyone else on the call who might have information for Diane. I mean, I have really focused the work that I've done much more at a household level, although I think the issues that you raise are really interesting, and I would be really fascinated to see the analysis that you're doing in terms of trying to take kind of an intersectional perspective on all of this.
Yeah. And Diane, this is Katherine. Actually, when we first did the heat maps, we actually included some of those connections because they kind of go in the other direction, right? Around if you make headway in SDG 16 and you really improve local involvement in decision making, then that can influence, obviously powerfully influence, a lot of these other targets that we would also want to see moved ahead. We ended up taking those out just because we were trying to keep the directionality kind of one way. Sort of if you invested in social production, you could see these downstream effects as opposed to kind of looking at some of those other more complex synergies. But you're absolutely right, they're there. And if we kind of let our imaginations kind of go where they should go, we'd have lots of, the heat maps would be much more full of interconnections.
Thank you for that. I will get in touch with you after the presentation because I think it would be really useful just to chat a little bit further about this as I do more work on the intersectionality between the two. My background has been in disability rights and looking at the intersection between disability, human rights and the SDGs. Which was really fascinating because it was talking about that multiplier effect and the co-financing that you talked about, that how that can be really, really good, especially around things like accessible housing and safe housing and what that means for women and girls, etc. And so, yeah, I will get in touch after this, but thank you for your answer and really great presentation. Thank you.
Sure. No, thanks very much.
Yeah.
We'd love to talk more.
And also, I mean, I think the point that you raise around housing is right on in the sense I've often thought as we have worked on Strive that if we knew what we know now, we would have probably chosen safe housing is one of the structural drivers or one of the structural factors that we would have focused on, because I do think it is very much related to so many different development outcomes. So I'll be really interested to see your analysis there. Do we have any other observations or questions?
There seems to be a question from Kate Harrison. She says, I wonder if there are any positive examples of national governments managing to take an intersectional approach. Well, I can try to respond there. So as Laurie mentioned, we're working with UNDP, who's sort of supporting countries to explore this co-financing approach, and which is all about taking into account these multiple outcomes and really taking an intersectoral approach to financing. And there are, so the countries are exploring different interventions that they might consider to do this with. And linking a bit to the earlier question, what we have seen is where this has happened, which this kind of co-financing has happened more in high-income countries, at least that's where we have documented cases. It has tended to be at a more decentralized level, and that might play into the role of local accountability, playing a role in seeing populations and their multiple needs in a less siloed way. So there are some promising experiences with actually doing this at more of a subnational level. And we're currently working with 7, so UNDP is working and we're supporting in 7 countries in sub-Saharan Africa to explore this. I mean, I have one that I've seen in Tanzania, and I think it reflects the situation in other countries with cash transfers as well, where they have been set up for mainly poverty reduction and sort of reduced social marginalization purposes and objectives. But there are other sources of financing that come in with other objectives. So, for example, in Tanzania, there has been some financing coming from the HIV sector to make it more, the cash transfer program and the social protection program more generally more HIV sensitive. There's also been financing coming from the environmental sector. It's financing that goes into the overall pool, but it's really buying into the fact that these programs tend to be working in areas that are dependent on forestries and so on, and they tend to then adopt projects that have an environmental dimension to them. So I think there are experiences out there. They're probably not labeled exactly as co-financing or in that way, but I do think there are models that we can learn from.
Do you know off the top of your head some of the ones in high-income countries that you mentioned? Like which countries have pursued some of this?
Yes, so we're actually conducting a review of those documented kind of cases that we found in the published literature, and my colleague Finn McGuire would be able to say more if he's on the call. But I think one of the main examples is kind of joint commissioning in the UK, which is has actually pooled together funding or budget from the health sector and from the social care sector, and kind of mandated that these budgets will become a joint budget, and that's how and that activities have to therefore be reflecting and achieving the multiple objectives of those two sectors. There's also been some examples in the road traffic safety field in the UK again, and there they found reductions in casualties actually. And then Sweden has had some work again at the decentralized level, where it was mainly the social care and the health sector, again, pooling resources together.
Well, we thank you very much. This was our first effort to try to bring this body of work together, and so any feedback that you can offer in your comments would be much appreciated. If you could fill in the questionnaire at the end of the presentation, it takes just literally a minute. We'd really appreciate it. And I want to thank everyone, especially Katherine and Michelle.